I'm Sanjeev Bhalla, and I'm the Section Chief of Cardiothoracic Imaging here at WashU in St. Louis, Missouri. So, this first case is a woman who is 24 years old and pregnant who came in with shortness of breath. I think that you don't have to really have much experience in reading chest radiographs to realize that it's grossly abnormal and there is a mass that is sitting somewhere in this person's thorax. The fact that it crosses the midline suggests it's mediastinal, and the fact that you can see the vessel running right through it, the so-called hilar overlay sign, suggests it's anterior mediastinal. So it's a very good look for an anterior mediastinal mass. But because she was pregnant, there was a desire to avoid doing a CT if that was at all possible. The mother was very concerned about getting the radiation. And because of the fact that she's pregnant, she's not really a candidate for getting gadolinium. Gadolinium contrast, as a reminder, is a class C agent according to the FDA. And so it's contraindicated in most pregnant patients, with the exception of those where you're worried about like a placenta accreta or percreta. So we did an MR to further characterize this lesion to get an idea of what was going on. And the MR is a really nice tool. I like this example because it allowed us to look at some of the sequences that we use routinely for MRI evaluation. So our MR standard chest protocol consists of doing coronal images with a very fast sequence. This sequence is one that is a single shot echo sequence, which allows for very quick images. So each image stands alone. So if the patient has trouble breathing, you don't have to worry about the whole volume having motion artifact. We also like to do images in what we call a T1 and T2 weighting. The T1 weighting allows for anatomy, and the T2 weighting allows to pick up pathology. So T2 is very water sensitive. And so when you see something that is kind of bright, you can go back and get a sense of where you are in the T1 images. Now, as part of that workup, we also do what's called in and opposed phase imaging. So in and opposed phase imaging has become standard in the evaluation of the chest because something like thymic hyperplasia will drop on the opposed phase imaging. So if this got darker on this opposed phase, it would suggest that water and soft tissue are in the same voxel, the water and the fat, and the net effect is that you get this drop of signal. So MR is very useful. It's a standard, actually, if you're worried about a patient where there's a lesion in the anterior mediastinum and you think there's thymic hyperplasia. This is clearly not thymic hyperplasia. It's not changing. Now, one of the newer techniques that we're seeing is diffusion weighted imaging in the chest. So this diffusion weighted imaging allows us to see if there is a change in the diffusion coefficient of water. So we tend to see restricted diffusion in pathology. So when we get this bright signal on the diffusion weighted image that becomes darker on the corrected image, this suggests that this is going to be a malignancy. So this is very helpful in helping to confirm that this is the malignancy that's there. Now, I will tell you that as part of a non-contrast MR, it's also useful to have these sequences which are designed to look at the blood vessels. It's a balanced, steady state image, and you can see blood vessels are nice and white. And so this is really useful. You can see there's the mass. Now let me draw your attention to the internal mammary arteries and veins, and you can see that this mass starts to wrap around those vessels. Now, when we see that finding, that's pretty characteristic of a lymphoma. So if you see that kind of wrapping around, you know almost immediately you're dealing with some sort of a lymphoma. Now, let me tell you also, if you look at the superior vena cava, you can see that there's vascular invasion. MR has much higher contrast resolution than CT, so it doesn't require contrast always to make the diagnosis. Contrast can help, but in this case, because of the patient's pregnancy, we wanted to avoid using that. And you can see that this patient has actually even had an embolism to the left side, and there's an infarct in the right lower lobe. So we have an anterior mediastinal mass. The anterior mediastinal mass is exhibiting signs of malignancy. It's wrapping around the vessels like a lymphoma, and it's invading in the superior vena cava. Our experience has been that when we have this caval invasion, it's much more typical of a non-Hodgkin lymphoma. And to be quite honest, it's much more typical of a B-cell lymphoma. So with the MR, we were able to look at these images and to offer the team that we were highly suspicious that this anterior mediastinal mass was a lymphoma, likely a B-cell lymphoma, and that's what it turned out to be on biopsy. The power of MR is that it does allow us to get this better uh, both contrast resolution compared to CT and better spatial resolution, say, compared to an FDG PET. The thing, though, about MR to keep in the back of your mind is it does come at a cost. It does take time to get these sequences. So this whole examination took about 35 minutes. And so you can imagine if you have a patient who has difficulty lying flat or is having some difficulty with breathing, that it's not an optimal test. But in the right patient, it does have some value. In short, this case is a nice example of a case that allows us to see how MR can be used as an alternative to CT. In a patient who clearly has an anterior mediastinal mass, a non-contrast MR allows us to get a sense of where the tumor is extending, in this case around the internal mammary artery and vein. We can see that it demonstrates features of a malignancy and that it has diffusion restriction, and there's also vascular invasion. That constellation of findings really suggestive that this anterior mediastinal mass is a lymphoma, and that's what this ended up being. And just a good reminder how MR with its superior contrast resolution can be a really good problem-solving tool in the chest.